what is it? The acute respiratory failure.
Okay, sorry, doctor, but today is 9th. So I was saying it's a makeup.
Oh, it's actually a makeup.
Yeah, today is 9th October, 5th October.
Or one of the ones we missed.
Yes.
Okay, great. Let's go ahead.
It's okay. Let's go ahead. Yes. Thank you.
So bronchiectasis is one of the two conditions that we refer to as suppurative lung disease. The other suppurative lung disease is lung abscess. By definition, it's a chronic destructive lung disease that is characterized by abnormal and irreversible dilatation of medium-sized bronchi. You have persistent and variable inflammatory process which damages the bronchial elastic and muscular, bronchial wall elastic and muscular elements, and clinically is characterized by a chronic cough and purulent sputum, often with periods of exacerbations and periods of relative quiescence of the disease. So the burden of bronchiectasis is not really well characterized. We don't quite know, how much of this disease we have, especially in our setting. And the burden or the prevalence will be influenced by things like access and uptake of childhood vaccination. So with increasing access to childhood vaccination, a bronchiectasis that is due to severe pulmonary disease in childhood is declining. The prevalence of tuberculosis, as you know, in our setting, we still have a heavy burden of tuberculosis. So you would expect a significant contribution of TB, pulmonary TB to bronchiectasis. If people don't have access to early identification and treatment of respiratory tract infections, then those are likely to complicate into bronchiectasis. Poor living conditions with pollution, household pollution, environmental pollution can also contribute to bronchiectasis, and also the ability to diagnose the disease. If people are not aware about a certain condition, it is likely to be missed. And therefore, if you are relying on healthcare data to determine the burden of that disease, it may be spuriously low, not because it's not does not occur in that particular population, but because providers are not diagnosing it, or they are not properly equipped to make that diagnosis. And that would occur, for instance, in the case of bronchiectasis, where we rely heavily on a CT scan to better make that diagnosis. So in terms of pathogenesis in bronchiectasis, we talk about a vicious cycle of infection and inflammation, where you have an original insult, whatever it is, and then we'll have microbial infection, impaired lung defenses, tissue damage, and ongoing inflammation. All these things working in sort of a positive feedback mechanism to perpetuate the damage that gives you bronchiectasis. The initiating insult, as I said, could be inhalation injury, like smoke inhalation, could be a foreign body, could be infection, aspiration, could be genetic conditions like cystic fibrosis, for instance, and these initiating insult or injury causes or leads to impaired mucociliary clearance and really initiates the vicious cycle that contributes to bronchiectasis. So this is a pathological specimen on your right of bronchiectasis. What you are able to appreciate are really these very thick airways. They are thickened. You can appreciate the suppurative, the exudate within the airways. All right. They are thick. They are dilated. So these are really they are much bigger airways than they should be. All right. And the sort of mucus plugging, you can see all sorts of mucus within the airways. And on this side, you can appreciate the dilatation of the airways. Okay, you know that's a very thick airway. How do you know that the airway is thick? Is that when you compare it with the neighboring blood vessel, it is much larger than the neighboring blood vessel. So in terms of etiology, we've said the initial insult could be infection, for example, TB, necrotizing pneumonia, pertussis, influenza, measles, etc. Could be systemic diseases like rheumatoid arthritis, ulcerative colitis, systemic lupus erythematosus, Sjogren's syndrome, ankylosing spondylosis, yellow nail system. These are all systemic diseases. Some of them are connective tissue diseases. Others have an immune-mediated kind of etiology. Could be due to bronchial obstruction from tumor, from foreign bodies, mucoid impaction like you can get in severe forms of asthma or allergic bronchopulmonary aspergillosis. Could be due to congenital and anatomical lung abnormalities of whatever origin or whatever nature, inherited conditions that give you a ciliary dysfunction, cystic fibrosis, alpha-1 antitrypsin deficiency. And then we have up to 50% of conditions which are of undefined etiology. Most of these will be congenital or due to acquired immunodeficiency disorders. In terms of evaluation of the new patient, the most important thing is to identify underlying cause, and where these are amenable to treatment, then you want to offer specific treatment. The evaluation should also be targeted at prognosis, providing prognostic information. So in terms of the history, what are the most important symptoms? These patients will present with chronic cough, productive or purulent sputum, with episodes of exacerbations that are characterized by general malaise, joint pain, increasing breathlessness. They may have hemoptysis, and obviously increasing amount of the sputum produced. You want to ascertain the age of onset, especially if you are looking out for conditions that are likely to be congenital, like cystic fibrosis or other conditions that affect the mucociliary escalator mechanism. You want to look out for associated upper airways disease like nasal polyps, history of severe respiratory tract infection like TB or measles, pertussis. So this is information that we usually obtain from a family member, like a mother. family history, including challenges of fertility, would point to diseases that affect the ciliary function. Look out for history of gastroesophageal reflux disease, asthma, and conditions that cause mucus plugging, as well as allergic bronchopulmonary aspergillosis. And your history should also evaluate the impact of the disease on the quality of life of the patient. Examination, most of the patients actually don't have any features. You may have cladding, especially with long-standing bronchiectasis and crack holes. So the investigations start with a chest radiograph. In bronchiectasis, you'll see vessel crowding, loss of vessel markings, tram lines, which will point to thick dilated airways. Okay. Cystic changes, you may see cystic changes on X-ray and evidence of TB. But generally speaking, the chest X-ray is of poor diagnostic sensitivity. It may be normal in most patients, but it's very useful after you've made your initial diagnosis to monitor progression of disease. We don't do contrast bronchograms anymore, but if you were to do those, then you can really appreciate this dilatation of the bronchial airways, the moderate size airways, together with these cystic changes here, which will be show up like a grapefruit kind of a picture, a grapes kind of a picture. The CT scan gives you very dramatic changes. It has a much higher sensitivity for diagnosis of bronchiectasis. You are able to appreciate these generalized cystic changes, which are due to bronchial wall, bronchial dilatation, and the very thick airways. Using CT scan, you can also classify the nature of the bronchiectasis. Other investigations are really related to identifying the underlying causes and also any complications. Fetal microbiology is very important for identifying colonizing organisms because you may need to provide specific antibiotic therapy for those. Total blood count, especially when you're looking for infection. Markers of inflammation like the C-reactive protein. Serum immunoglobulins may be important when you are suspecting congenital or acquired immunodeficiency states. And if you are suspecting allergic bronchopulmonary disease, then you may need to do the Aspergillus IgE or the prick test, the skin prick test. Other investigations will include esophageal studies if you are suspecting gastroesophageal reflux, ciliary studies if you are suspecting ciliary disorders that affect ciliary function, like the Klinefelter syndrome, cystic fibrosis genotype or sweat test, semen analysis where there is evidence of infertility, foreign body you may need to do a fiber optic bronchoscopy where you're suspecting airways obstruction by foreign body or any other reason for obstruction, and lung function tests. So, as I said, the disease presents both in quiescent stages where it is relatively stable, or with exacerbations. And most exacerbations are due to a viral infection with bacterial infection. And the common causes will be things like Haemophilus influenzae, Haemophilus parainfluenzae, and Pseudomonas. And the less common causes would be strep pneumo, Moraxella catarrhalis, Staph aureus, and Stenotrophomonas maltophilia. As you can see, the range of bacteria that you see in bronchiectasis is slightly different from, actually markedly different from what you see in community-acquired pneumonia. So this is a very important distinction between community-acquired pneumonia and bronchiectasis. The management, the aims for management is to improve survival, preserve lung function. As we said, this bronchiectasis is a progressive disease, so you want to attenuate or slow the continuing damage, which will, further compromise lung function, prevent exacerbations, and improve quality of life. So what are the management principles? You want to start by patient education. You want to educate patients about their condition and what they are going to do, their own contribution to managing the condition. Then you want to provide airway clearance interventions, which we will talk about briefly. Reduce bacterial load, because what happens with bacterial load is that these will cause further damage and inflammation. So you want to make sure that exacerbations are treated properly, and in certain conditions there may be room for antibiotic prophylaxis, where, for instance, you have chronic colonization by things like Pseudomonas bacteria. There is room for antibiotic prophylaxis. Anti-inflammatory therapy may be indicated, and obviously, importantly, this Sorry, I think for a while I lost you, or I don't know. Can you hear me now? Hello, class rep, are we together? Okay, great. So postural drainage is one of the ways one of the ways for airway clearance. So the patient lies in an inclined bed like this, and then they percuss their chest to mobilize secretions out, which they cough out. So you can see the receptacle here. Okay. I think there is an interference with the, I don't know whether it is the class rep, because now I'm not able to share my screen because it's disabled.
Sorry, Dr. Meche, I've enabled you again.
Okay. So where we so what I was trying to explain here is this is a form of airway clearance. Other forms of airway clearance are percussion, deep breathing exercises, huffing, using what we call incentive spirometry. We have vests that provide vibration of the chest to mobilize secretions, and so on. So that's one way of so these patients need to be referred to a physiotherapist who has trained in the specific techniques for airway clearance. So that's it. So we have a question here: Can lung transplant be done in severe cases of bronchiectasis? Yes, lung transplant is possible for severe forms of bronchiectasis, but as you are aware, that is not available in our country. We are yet to have lung transplant as in an intervention in this country. So where that is required, where people have to travel, and these are things that are extremely costly, where they are done, nationals are prioritized over and above people that are traveling from abroad. So the methods for airway clearance, we have postural drainage, which is the image that I am showing. We have percussion, chest percussion. We have huffing is as another method of airway clearance. I think we can have a therapeutic sessions where we can go through some of the airway clearance techniques. We have devices called flutter devices, which help to mobilize secretions, and then the patient can cough them out. So those are some of the airway clearance techniques. For patients who have cystic fibrosis, which is quite rare in our setting, other things that you can do are give medications, which liquefy or reduce the viscosity of the secretions, like DNase, and so on. Please explain the utility of semen analysis in investigation for cause of bronchiectasis. So if you recall from your, and I hope you did not miss that class, from your histology, you will recall that the way that sperms move, that mechanism is the same as what is utilized by the cilia in the airway. And patients who have genetic abnormalities for that mechanism will present with so also remember, you also need cilia for the movement of the what is it called, oocyte from the ovary. So these patients will present with infertility. So doing your analysis will point to a genetic reason for what you are seeing in the what you are seeing in the airways. So go and review the mechanism for the mucociliary escalator, how the cilia move. That same mechanism is used in the fallopian tubes, but there is also the same mechanism that is used for movement of spermatozoa. Okay, any other question? I think we have exhausted all the questions that have been asked. So okay then, so thank you. We've covered bronchiectasis, so we will look for opportunity for you to go through respiratory failure. Thank you and have a nice afternoon.
Thank you, Doctor.